All right, hello and welcome everyone to our next webinar installment. As Michelle just mentioned, we will be recording this, which will be posted on our website for those who are unable to attend today. We will also be monitoring the chat box throughout the presentation, so please do not hesitate to post any questions that you may have for Michelle throughout the webinar. My name is Jennifer, and I would like to introduce our speaker today, Michelle Hager. Michelle is the managing partner at Cirrus Consulting and has over 20 years experience in healthcare IT. She is active in HIMSS, having held roles as a South Carolina chapter president, vice chair of public policy, and chapter advocate. She has worked diligently throughout HIMSS to educate the industry and public on healthcare IT, public policy, and the future IT strategic directions, including telehealth policy. Most recently, she was inducted into class of 2022 American Telemedicine Association College of Fellows. This fellowship, only awarded to a select few each year, is a high honor which recognizes significant achievements in telemedicine, service to the telemedicine community, and as well as within ATA itself. And with that, I would like to hand it over to Michelle.
Thank you so much, Jen. I appreciate that. Thank you everyone for attending. Today, we are going to talk about an unusual topic, kind of a futuristic topic, I guess, something that's been out in the ether around telehealth and telemedicine practice. But I do want it to be a conversation. So as Jen mentioned, we do have the chat that we're monitoring. So please jump in, comment, questions. I'm happy to answer them. This is a very this webinar is designed to be sort of thought-provoking discussion on what virtual first means and what virtual first could mean for the industry. So first of all, let's look at what does virtual first even mean. There's a lot of different thoughts around it, so we're going to kind of frame it in a certain way for our discussions today. But the Journal of American Medicine published a statement back in October 2021, or made this news that said United Healthcare was going to announce the launch of a lower premium virtual healthcare plan for primary care. So for patients, they could select a lower premium service and they could do on-demand services. And in this case, this was potentially utilizing their doctor on demand solution. We also have very similar offerings from Humana, Aetna, and other regional healthcare plans. So you can kind of see where the insurance companies are headed in terms of incentivizing patients to choose lower cost plans in order to have more lower cost solutions like a telehealth visit. And you can see there as you read on in this JAMA article as well, Firefly Health, which provides virtual first primary care services, has announced it will be offering its own health plan. So now you see this crossover between healthcare plans, insurance plans, and telehealth companies where they are offering not only the insurance offering, but the telehealth solution as well, and vice versa. So that'll be interesting to see how that progresses, and potentially how that affects the market and the compression with the insurance companies and the telehealth companies themselves. And we know that, for example, MD Live was acquired by one of the insurance companies, I believe Cigna off the top of my head. And so we'll see this kind of compression in the market as we see things moving forward. In addition, we see a plan in Michigan, Priority Health, offering coverage requiring online virtual visits for non-emergency care. That's also true for Harvard Pilgrim, which has now just recently changed their name. I can't recall it off the top of my head, but they are one of the largest healthcare insurance plan providers in the New England area. So the virtual first solution is a true primary care physician replacement product. Essentially, you can see that in the quote down there at below from Priority Health, which said that they are interested in looking at these lower cost solutions for patients. Instead of having patients go over to a brick and mortar location. So there are some pros and cons around this. I want to talk about it. And that's why I was saying, let's ask some questions in the chat if you have them, or comment. I'm very interested in everyone's thoughts on this. Skeptics do see a downside, and that someone may actually miss an important healthcare issue that's happening with the patient if they're not actually seeing them. And so what's the right balance there? Is there some regularity that we need to put out there in terms of rigor or regulation related to how often you actually have to see a person in order to be able to continue to do telehealth solutions? And we see this kind of bearing out in some of the regulation we saw in CMS's requirements to do 6 months for behavioral health services, to come and do an in-person visit every 6 months. So that was kind of their first attempt. There's a lot of pushback on that, of course, because folks are saying, why is that? How is that clinically necessary? Let's base it clinically versus just an arbitrary time frame. But these are the kinds of things that folks are grappling with this new and clearly disruptive technology. In addition, we see Amazon's CEO noting that in 10 years, visiting a doctor's office will seem insane. The current experience, where you have been doing this for over 100 years, will be obsolete, in the same way that we see things like Blockbuster and banking in different ways. And I'm sure you all have heard of those examples, but it will fundamentally alter the telehealth game. And of course, Amazon, having such a massive logistical experience, will have an impact on the industry. In addition, Deloitte did some research around this as well, and said at least 25% of ambulatory care visits would be virtual by the year of 2040. So we know that the numbers have gone down post-COVID, but we will see this push because we now know that it's possible to do visits via telehealth in certain clinical scenarios, that we'll see some push by the healthcare industry, by the insurance industry, and by healthcare executives to try to grab some of this new market in order to be able to accelerate virtual care. Interestingly enough, we also see businesses choosing virtual first. You can see the cost reduction. In this case, Dropbox is making its workforce virtual first. So they have to work virtually as a first step. And because the expense of real estate, expense of the commercial space for them to kit it out, for them to manage it and have all the benefits that people require now in employer-employee relationships. And we all know those. We've seen them on Apple and Google and commercials and movies, et cetera, snacks and entertainment and food and all sorts of things. The expense of the building itself and all of those other amenities for those employees, they are looking at pushing this to be a virtual first. And employees are liking that. So if they like it in their workforce, why wouldn't, in their employment, in the workforce scenario, why wouldn't they like it in healthcare as well? So a constant push towards this virtual first approach. And we have to do something. There's a rising cost of care. This is the most basic tenet that we all know in telehealth or in healthcare. The cost of care is unsustainable. The clinical shortages that we see are unsustainable. So in 2020, we had projected that we would have a physician shortage of 90,000 physicians. Now with COVID, that number is extended. And by 2025, over 130 physician shortages across the country based on the number of population that we expect, the population growth over that period of time. So the supply and the demand are absolutely out of whack, and the cost is out of whack. So how do we make a change? How do we utilize this idea of virtual first, or can we utilize this idea of virtual first to bridge the gap between physician shortages and the rising cost of healthcare? Certainly the insurance companies are thinking that this is a possibility by offering those lower premiums to go to a virtual visit first before you head to that brick and mortar building. The market has absolutely exploded. You may have seen this graphic in other webinars that we've done previously. It's absolutely gone crazy. 2027, the investment in the industry is so heavy, 285 billion across the global market value. This is unprecedented growth. That means there's a tremendous amount of investment in this space. And at the same time, we see pressures from the market related to telehealth companies, suggesting that some of these companies are just being propped up by investor dollars, and there's actually not that much demand out there. So there's a mismatch in the amount of dollars that are out there in investing in the market and what's happening with the stocks of some of the largest telemedicine companies. But the greatest impact from COVID in 2021 was, of course, the loss of revenue in hospitals due to delayed or reprioritized elective surgeries. And then the third one down, just the one I wanted to make you aware of, was the increased telehealth usage. That's obviously a huge impact in 2021. In addition, we know that the decline in commercial insurance enrollments due to the rising unemployment cost is also a major change in healthcare and how healthcare is going to be delivered. And we know that there's a mounting backlog of surgeries because those surgeries weren't done or procedures weren't completed during COVID because they were delayed because of obviously exposure to potentially the virus. Excuse me. In addition, what I wanted to draw your attention to here is how healthcare organizations view their greatest challenges. This was and they view their greatest challenges as the changing of the care delivery model. This goes straight to the heart of virtual care, telehealth care, and all of the digital tools around the changing of the way that we deliver care. In addition, we have to achieve physician alignment and hospital network for quality, access, and efficiency. I would also suggest that this includes physician and clinician burnout. So there's some alignment that they have to do in order to ensure that they don't lose very skilled clinicians at a time when physician shortage is a crisis. And then as you move forward, you can see that COVID regulations are a challenge for them, cost of care, investing in better data structures, and then pandemic management protocols. But down at the bottom, what's important is what about the health equity? We've seen that this has drawn sharp attention between racial and economic disparities in healthcare. There's been some data that's shown that maybe racial disparities aren't there, but in this study from Commerce Healthcare, they said there are some racial and economic disparities that are happening. And we have to make sure that we're delivering care that's culturally competent and takes into consideration the social determinants of health that contribute to those health inequities. All of that has been elevated over the course of the last 2 years through COVID. Because when we see patients moving more and more to a digital platform and pushing healthcare insurance companies and workforce all pushing to a digital platform, we start to get into these health inequities where broadband is still a challenge, technical is still the challenge, devices in the communities are still a challenge. So these are things that we also have to consider as part of the ecosystem of better caring for patients. This study by the Commonwealth Fund I thought was very interesting, and I put all of my resources out there so you can look at these slides later and you can look at their full article. But the top performing countries overall related to healthcare, the United States ranks last overall, despite spending far more of its gross domestic product on healthcare. And we've probably heard this statistic before, but what's interesting is that we actually rank first in measures of care. So we rank last in access, but we're, second in measuring of care process. So we do a great job of measuring what's going on with the healthcare system, but we do a not so great job in performing and the spending that we do with healthcare in general. So the 4 top performing countries from the United States, they provide universal coverage and remove the cost barriers. So again, cost is now not a function. They invest in primary care systems that ensure high value. So potentially this telehealth solution, they reduce administrative burdens, and they invest in social services, especially for children and working age adults. And when we look at the next slide, you can see their telemedicine productivity actually falls right in line. So these are some of the greatest countries that have utilized telemedicine over the last year or so over the course of the pandemic. And you can see that the United States is actually not on this list. So those countries that have more of a cost-based model versus a revenue-based model have done better in their adoption of telehealth. And I know we have a comment, excuse me, that was a reminder that we are commenting in the chat. If you have any comments or questions along the way, please feel free to add those into the chat. We will be monitoring those throughout. So what do we think about in terms of the next step? So when we look at the journey of healthcare in the 90s, we saw that we had a paper-based system because we know that telehealth is a disruptive technology. There's no question about that. So if we look kind of at the disruptions across this timeline, in the 90s, we're looking at paper-based medical records, which we all despised, even though there are still some out there. And then we saw HIPAA come into play. So now we're paying more attention to patients' privacy, which is part of our day-to-day. Now it's all part of our DNA, HIPAA is. We know that there's, in the 2000s, we brought some attention to 98,000 patients that die each year from medical errors. So we needed to do something in order to be able to manage that. And then we started to see this push for computer-based patient records adoption, or what eventually became an EMR. And as time goes on, excuse me, the National Coordinator Office was established to be able to monitor those new technologies and certify them. And in 2009, we now have the HITECH Act, which ensconced ONC to provide that leadership and overall national adoption of EHRs. And we can debate that, what did that do to the industry? But I think what's important to note is these are major changes in healthcare and how they moved the needle forward. And I'm proposing here that telehealth and this idea of virtual first will do the same. We then have the adoption of accountable care organizations to try to reduce cost and try to find new and different ways to pay for healthcare. And then CMS started to create the incentive plans, incentive programs around healthcare delivery. And as we move forward, you can see that the implementation of MACRA, excuse me, and MIPS, that's what I get for not having my water today. This has changed the way that things have moved forward. We're able to look at physician fee schedules a little bit differently. And of course, that motivates things in a different direction. And meaningful use. We will never forget meaningful use. And in fact, it is this year that is projecting, 2021, that was projected to be the final year of any of the EHR incentive payments related to meaningful use. So when we look beyond this roadmap and we look to the next step, could that be a digital health, a virtual first solution as our next journey in healthcare, our next big thing, if you will, related to healthcare? Something to think about. Will it be this idea of personalized medicine? Will it be part of the ecosystem of artificial intelligence, machine learning? Will that be incorporated into virtual medicine and virtual first in that same way? We know that when we look at mHealth and how this works, again, we've got our references here, but our telemedicine devices, monitoring data, reporting data, and giving that patient that information, that real-time information, for them to make changes in their own healthcare real time. And yes, some of that data goes back to the physician, and they may analyze that and share some results and make changes. But for the most part, this is coming back into this loop of a patient putting data into a monitoring device and the technology providing guidance back to the patient. So very interesting use of artificial intelligence and machine learning. As you think about this from a practical perspective, could you take virtual first in all the non-complex care visits? Could you have folks that have potential urinary tract infections, earaches, sore throats, etc.? This is a Tyto Care solution. You could buy this from Best Buy. You probably heard of this some time ago. You could buy this at home, use this at home, and it would allow you to access a clinician right there in your own home by providing them this specific data, whether it's information about your throat, your ears, whatever it is that's going on. It gives you a good amount of tools. So rather than us just having a thermometer at home, we would now have an otoscope. We would now have a bit of a stethoscope, those types of things. So we've evolved in the home now to be able to care for ourselves and our families. What about medication follow-up? Could those be mandated by the insurance companies to be virtual first, unless there was some level of complexity which required the patient to come to the office? What about post-surgical wound exam? We already recommend that in the telehealth space for folks to be able to move patients more quickly and increase capacity. Again, what if the payers required that? Again, unless there's something specific which requires them to do a brick and mortar visit. Dermatology makes complete sense. We all know that if they could take a picture and send it, and if that's the priority for dermatology, consider that as your first entrance into a dermatologist's office. I have to take a picture of what I have, send it via secure process, store and forward process to the dermatologist. The dermatologist then determines, or other clinicians in the office, determines whether or not I come into the office. Now, I know from a clinical perspective, there's some cancers that some folks might want to see, and you can still do that. But what if the payers require it? What if regulation requires it? What if, because we have so few physicians, clinicians in the industry, we actually have to do that? So these possibilities are vast, and what will the 10 years from now look like? But this is today. This is the BrightMD Smart Exam. And right now, patients are utilizing this in health systems across the country. It's asking a question: how would you describe your pain? It asks the patient, if you pull this way or you pull this way, what does it feel like? Does it hurt pulling out or pushing down? So these are smart exams which guide the patient to do their own exam, essentially their own physical exam. And in this, and in many cases, it triages them to just getting a prescription and never seeing a clinician. So a nurse or nurse practitioner might review that smart exam based on the patient's history. They would be able to go through that interview somewhere around 5 minutes, get that information within an hour, and the prescriptions are sent directly to the pharmacy. Consider that in the Amazon comment that we heard earlier from the CEO of Amazon. How disruptive would it be for Amazon to provide that same clinical service via virtual care and then potentially deliver your prescriptions to your doorstep within X amount of time via a drone, via whatever process they decide to do in certain areas? That could be a serious game changer. How would that change the market for a CVS, for a Walgreens, for a Walmart? That could change their market quite a bit. If every Prime customer from Amazon was able to get a prescription within, say, an hour after a visit, just droned to their home, whether that's for their sick kid or for themselves, that would be huge. How many moms are out there like me, where you've got a sick kid and you don't want to drag them to the pharmacy to wait in the line, to wait for the prescription to be refilled? This is happening today. So where do you see this virtual first coming up? practically, I see it coming up in the insurance verification process in a hospital. This is a medical billing process and standards. But in insurance verification, at that point, we find out, we get pre-authorization, we determine whether or not the patient's insurance is going to cover the visit, and we could find out right away, should they go the virtual first route? And that's where I see this coming into play practically. So prior to prior authorization and claims processing, we would know that the patient was not eligible to do a brick and mortar visit because they hadn't done a virtual visit. You'd have to collect a payment right then, or you could say, here's a kiosk and you can go over there and do your virtual visit rather than being here in brick and mortar. You can just see how the practical elements of this would play out. And from a staffing perspective, the numbers are bearing out as well. Physicians and staff spend over 20 hours per week just on prior authorizations. For those of us that have worked in the hospital, you know, there's whole teams of people that do pre-auths. And some of those will still be required, of course, because, you know, surgeries, et cetera. But 92% of those prior authorizations process delays patient access to necessary care. It delays patients' access to necessary care. So if we now have a virtual requirement that they do that first, presumably care would be more quickly. People would get used to the fact that I can't do a brick and mortar visit. I have to do a telehealth visit first. Let me go on the telehealth doctor. I mean, how many of us with kids go to a pediatrician first only to be then referred to an orthopedic or a gastroenterologist? So this is the same process that we would see under normal circumstances, just using a virtual first approach. But we do need to consider ADA. For patients that have vision or hearing or mobility or memory issues, using technology can be very challenging for them. And we don't want to create health inequities for those very patients that are the most vulnerable. So ensuring that patient education and orientation is given in lots of different options, including technology. Don't necessarily send patient instructions as images. Maybe you just need to, because they don't have access to it on their phones, maybe you just hand them a piece of paper. So there's logistics here, and we can talk, this isn't a talk about all the technology challenges. I'm assuming, let's say that all technology challenges are resolved, right? Broadband, device issues, unlimited plans, all of that is leveled. Let's look at what could telehealth or virtual care do and be for patients. And again, mobility, those that need a special help in order to be able to do activities safely and unaided, that could limit them in terms of typing or sending documents. So again, as we talk about virtual care every day, we always use a patient selection criteria. So that would also come into play here as well. Let's talk a little bit about AI, artificial intelligence, and machine learning. If we utilize artificial intelligence and machine learning today, which we do in many areas like identification of disease, you may have seen a tool that is, you could search this on Google, that takes a picture of your skin and it will define whether or not there's cancer. You know, skin cancer on your skin, that is being utilized today. Medical imaging, excuse me, drug manufacturing and discovery, and then also smart health records, disease prediction, personalized medical treatment. So all of these machine learning technologies are currently being utilized in healthcare and could be utilized even more in healthcare to help with medical decision making, as well as, and I'm sorry for the blurriness on the bottom image there, but as well as allowing for AI to do predictions on patients and determining whether or not the patient would be potentially a challenge in terms of readmission, or based on what their skin condition, they might not be eligible for just doing a store and forward scenario like I talked about earlier. And then what about the governance of this? How do we handle the governance of AI? Because now we're talking about a machine AI learning on its own without just dumb information being fed into it, just like you would with medical evidence-based medicine. This is more than that. This is a technology that's learning, that's evolving, that's making decisions or helping to make decisions about your medical care. So then that gets into this ethical question. I listened to a great talk with one of the premier lawyers in telehealth. You may know Joe McMenamin did this presentation recently at the Center for Telehealth Policy and E-Law Summit and talked about AI and machine learning from a legal and regulatory perspective. So from an ethical perspective and legal and regulatory, since the machine learning and the AI is learning on its own and is not just being a dumb, connection or a dumb terminal, essentially, it's doing it on its own. Is it now a clinician of some type? Does it have to have malpractice insurance? Do we need to have some other types of considerations around the ethical questions of a machine that is actually learning on its own, artificial intelligence that is actually growing and becoming something different day by day, minute by minute, with each passing patient that it sees? So these are big questions that will have to be answered in the future. But this is definitely part of the virtual first ecosystem, because if we do virtual first, how far do we go? Do we go to this place where you can take a picture of your skin and it will tell you via the machine learning that you have potentially skin cancer and whether or not you need to go to the doctor or not? That's the part that would make the big difference, right? That you don't do something or you do something which could make it worse. So these are ethical questions that we'll have to wrestle with as time goes on, but something to think about as we're considering this idea of virtual first. I always want to thank the healthcare heroes that are on the call. You all are front lines, taking care of patients every day. Thank you so much for everything that you do. If there's ever anything that you need from us, please let us know, but thank you for everything you do on a day-to-day basis. Our session is completed. If you have any questions or you want to talk more about this or you want to have a conversation about this topic, please feel free to email me, call me. I would love to talk more about this. This is kind of a beginning stage, and I think what we'll do is have a little bit of a virtual first jam session with some other folks in the future, just to talk about some of the challenges and opportunities that virtual first could provide to us as time goes on. Thank you so much for being here, and I'll entertain any questions that folks may have. I don't see anything in the chat, but if you do have a question that you don't want to pose here in a public forum, as I said, email me, call me anytime. You can always re-watch this presentation and we can talk more about virtual first. There was only a limited amount of topics that I've covered, of course, but you can see how the changes in healthcare will be made with big leaps. And I think since COVID allowed the opportunity for telehealth to become an even more important tool in the toolbox, we'll see that be a new avenue, a new change point, a new crossroads for telehealth or for healthcare as time goes on. Thank you for your attention. Thanks for being here today. And we do these webinars each month, whether it's a lightning webinar or a full webinar like today. And please enjoy our others that are saved on our knowledge tsunami on our website at blue-cirrus.com. Thank you so much for being here.